Hello, and welcome to today's webinar, A Structural Framework for Meaningful Use of Electronic Health Records in the Healthcare for the Homeless setting. This webinar was made possible by a grant from the Health Resources and Services Administration, Bureau of Primary Healthcare. My name is Melissa De Silva, and I will be serving as your moderator for this one-hour presentation, which will include Q&A in the last 10 minutes. At any time during the presentation, you may type your questions for our presenters into the chat box below the presentation slide. Note contact information for Sarah Knopf, who's available to answer any of your technical difficulty questions. The PowerPoint and recording of this presentation will be posted on our website within 3 business days. In 2010, we launched a TA and training initiative to support HCH grantees in their pursuit of PCMH recognition and becoming meaningful users of EHR. Since then, we've produced webinars, workshops, trainings, on-site TA, and our webinars have featured a variety of Healthcare for the Homeless grantees and other health centers, including Columbus Neighborhood Health Center, Christ Community Health, Heartland Health Outreach, Yakima Neighborhood Health Services, Mary Howard, Hudson River, Duffy Health Center, Boston Healthcare for the Homeless, as well as some notable personalities from our federal partners at the Office of the National Coordinator, Dr. David Hunt, and today our esteemed guest, Dr. Yael Harris. Dr. Harris is Director of Office Health IT and Quality at HERSA. She works there to support HRSA in their efforts to improve the quality of care through the use of technology and information. Prior to her arrival at HRSA, Dr. Harris served as Director for the Division of Evaluation in the Office of the National Coordinator for Health IT. She served as the staff lead for the Health Information Technology Policy Council Subcommittee on Meaningful Use. Prior to joining the ONC, Dr. Harris worked for the Centers for Medicare and Medicaid Services, where she led efforts on measurement and quality improvement in long-term and post-acute care. Before joining the federal government, she worked for a congressional advisory body at Georgetown University's Institute for Healthcare Policy and Research and served as an advisor to lead staff on the House Ways and Means Subcommittee on Health. She holds a doctorate in public policy from the University of Maryland and a master's degree in health sciences from Johns Hopkins University. Dr. Harris is also currently adjunct professor at the Erickson School of Aging, where she teaches courses on technology and aging services. Our amazing and wonderful all things PCMH and meaningful use guru and TA consultant Anna Gard will be our first presenter. Anna is also a health disparities consultant with the Association of Clinicians for the Underserved. So I will now turn the mic over to Anna Gard to begin this presentation, today's presentation on meaningful use. Anna?
Thank you, Melissa, for such a wonderful introduction. I hope I can live up to what you say. Welcome, everyone. Thank you for spending some time with us this afternoon. And today we're going to speak to you about a structural framework for meaningful use of the electronic health record. So what is so meaningful about meaningful use? Well, simply put, meaningful use means providers need to show that they're using certified EHR technology in ways that can be significantly measured in quality and quantity. And if you are able to demonstrate this, then you would be eligible for some incentive funding from CMS. Some of the opportunities that we hope to achieve through meaningful use of health information technology is improving quality and safety, engaging patients and families, and improving population and public health, with a real focus on some of the high-leverage areas such as disease prevention and chronic disease management. You may have heard about the stages of meaningful use, and in fact, last November we presented a webinar through the Council on Meaningful Use Stage 2, and we had Robert Anthony from CMS speak about Meaningful Use Stage 2, and Lance Luttrell from Christ Community Health Center spoke about their organization's movement in attesting to Meaningful Use Stage 1 and moving towards Meaningful Use Stage 2. I'm not going into the details of meaningful use stage 1 and 2 but to let you know that we have resources at the Council to refer to that, as well as we will be addressing this in more detail at the national meeting in Washington, D.C. But as we look towards the use of electronic health records and meaningful use, and we move through the stages, we recognize the need to integrate systems. And that is not just the electronic health record, but to begin to look at health information exchange. How do we share the information and data that we are capturing in our electronic health record and share that with other health organizations, whether it be the hospital, home health agencies, specialists, as well as with patients, and that's where the personal health record comes in. So as we look at integrating the systems, we look at focusing more on how do we, with the integration of these systems, begin to look more closely at advanced clinical processes, identifying risks of our patient population, supporting chronic disease management, and improving quality care through care coordination and care management with decision support, education, alerts. And as we move towards stage 3, really working on demonstrating improved health outcomes. So people get ready. Is this prophecy or promise? Being able to improve our health quality and safety with the integration of health information technology and electronic medical records. In January of this year, there was an article released from Health Affairs that looked at some of the challenges in achieving our goals towards improved quality and safety. One is still the adoption barriers. That in the U.S., there's only 40% of physicians and 27% of hospitals have adopted EHR. In 2011, the Council participated in a survey of HCH grantees in which we had a 95% response rate that showed that our HCH grantees had 66% in rates of adoption. Some may have been partial adoption, but our grantees are well on their way and above the national average, which we were happy to hear. The meaningful use incentives from CMS are helpful to support adoption and implementation, but it's not enough money to close the gap, particularly with small, rural, non-teaching hospitals and smaller health systems that are serving vulnerable populations, which is the population that we are serving. And that there's limited patient engagement uptake. Only 42% of patients who are eligible to access their personal health records through either PHRs or patient portals have signed up for this, and less than half have viewed their personal health records more than once in 2 years. And why is this? Why do we continue with adoption barriers? Well, some of it is usability, that there are vendor market issues. The current vendor systems require significant training. If any of you have already gone through training, you know that the user training manuals are thick and cumbersome. Accessing the vendor for support can be difficult and time-consuming. There's a significant amount of training that's involved of all staff to get up and live. And then continued upgrades and customization are required in order to really make the system work for your practice. Many health centers lack the IT staff support to support a system, and so they are scrambling to either retrain some of their current staff or not putting in the needed IT expertise to fully support a system. And vendors really have fallen short on engaging the clinician community in their software development. And so clinicians find the software to be cumbersome and not complement their practice, which really inhibits full adoption from clinicians. And we continue to have some significant challenges with health information exchange, really due to interoperability issues, that one vendor does not readily or easily interface or speak to another vendor, and therefore the sharing of information from health center to health center to specialist to primary hospital and back, there is not an ease of use between the two systems. We also recognize that once we have this technology, one of our barriers is we are trying to fit the technology into our current work processes, where in fact we're recognizing that the technology is just a piece of the whole practice redesign or transformation that needs to happen in order to attain our goals of improved quality and safety. So when we looked at these barriers and we looked at adoption rates, last year I spent some time interviewing some of the HCH grantees who are further along in the process and have attested to meaningful use stage 1 and are moving towards meaningful use stage 2. And we came up with a structural framework that was common amongst the healthcare for the homeless grantees in their implementation adoption of electronic health records. That is a document that we published and is available on the Council's website, but we wanted to use this opportunity of the webinar to give you what we discovered in our interviews. And the first piece is engaged leadership. That leadership that demonstrates a commitment to health IT and the transformation process necessary for implementation sets a clear example for the organization that quality improvement is a priority goal and that health IT is a necessary tool to succeed in meeting the organization's missions and goals. That without the leadership really holding this as a valuable initiative, it makes it very difficult for this to be a successful venture. And just a promo that in March annual Healthcare for the Homeless meeting, the Pre-Conference Institute will be focused on leadership. And also there will be a workshop focused on patient-centered medical home and engaged leadership that will be focused on the guidelines developed by the Safety Net Medical Home Initiative. So there are two really great opportunities to learn more about leadership and leadership development in moving forward both technology and practice transformation. Strategic planning. And I would like to credit Lance Luttrell from Christ Community Health Center with this concept. And he talked about how when they began this process, they really laid out the why first before they talked about the what and the how. And that is looking at what is the mission, the why. Why are you implementing and adopting electronic health record and health IT? How does that marry with your mission and the mission of your organization to provide quality care, access, safe care to your healthcare for the homeless population? What are you going to do in order to support the why? And that is to adopt technology that will support our goals. And in doing that and looking at what, assess your organization's time, talent, and treasures. How can you capitalize on what you currently have in your organization that will help support this process? And then how? And looking at and recognizing that health information technology value is in direct proportion to how well it is being used and how many people and organizations are using it. So that once you identify the technology that you're going to use, you need to strategically plan how is that going to be used, who's going to be using it, and recognize that it's only a successful tool if it's being used appropriately. I just wanted to use this example of University of North Carolina Health System did a great job as they did their strategic planning of setting out alignment with their organizational priorities. And it's a really great place to start because their health system decided that as they were adopting and implementing technology, they obviously wanted to meet the meaningful use measures so they could qualify for the incentives. But at the same time, they wanted to start the process for patient-centered medical home recognition. And they had other standards that they needed to meet. At the same time, they were doing JCHO. For some of the health centers, they need to report on their UDS measures. So they designed a strategic framework with alignment of all their priorities and began to match up which ones aligned and then strategically map out who was responsible and what team was responsible to making sure that these processes were in place. The next piece is figuring out the finance, focusing on the finance, and all the organizations that, healthcare for the homeless organizations that I interviewed really talked about how finances are clearly a big piece. As we said, it's important to register with CMS to understand the financial support resources and the incentives available, but we do know that those incentives are not enough to sustain an implementation because the costs continue outside of just purchasing the software and implementing the software. You have hardware costs, you have annual maintenance costs, and I've seen some estimates that have said that the annual maintenance costs are estimated to be about 20% of your first-time initial investment. So in terms of budgetary issues, finances is a very important part of your strategic planning. This is just a chart of the financial incentives. I'm not going to go. Providers can participate in the Medicaid incentive program. And 2015 for Medicare, those organizations who have not begun attesting to meaningful use will start receiving reduced Medicare payments. So this is really important to be familiar with what the time frame is. The next step is building a IT and a QI committee. And this is a very important step because it is a labor-intensive process that you need this committee involved in your strategic planning and then also for the implementation. This committee should be a multi-department committee that guides all aspects of the project, including initial implementation and rollout, introduction of any new functionalities, being responsible for project management of interfaces and reporting. A clinical subcommittee is a very important part of this committee because they need to review the clinical content development of the software, clinical workflows, as well as clinical functionalities. Advantage Healthcare for the Homeless in Michigan said that they built a multidisciplinary committee and they met weekly to facilitate the implementation, the strategy, and the execution. And if any of you have seen Field of Dreams, which is where I came up with this idea, when we think of building this committee, you can't just have one person be the pitcher, the catcher, and the batter all at once. This is really a team effort. And that effort really comes from multiple disciplines, from your IT department, from your operations department, from your leadership department, and your clinical department. The power of communication. Design your communication strategy. How are you going to communicate any of the changes, the workflow processes, the updates to your organization? By keeping your staff informed of progress, you will engage the interest of your staff and also get buy-in of the new system. Generally, people don't like change. It makes them uncomfortable. So making sure that you communicate change ahead of the change will give them some time to provide some feedback, to ask some questions. Organizations do it differently depending on how they are set up. I've seen organizations who have printed announcements on their web portal. Every time their staff turns on their computer, there's an announcement that pops up for, oh, this week there's going to be an update, or this week this workflow process we're going to begin this workflow process. Sometimes there's flyers, there's posters, there's dashboards that are disseminated to the staff. It's discussed in staff meetings. But making sure that communications are shared about workflow, about information exchange, about education and training opportunities, and also making sure that part of that strategy incorporates an avenue for feedback and questions of the staff. If the staff are engaged and involved, you're going to get greater buy-in. Installing an IT strategy, and this is particularly significant for HCH sites that have multiple IT connectivity issues due to a variety of infrastructure challenges. Mobile sites, old buildings, clinics co-located in rented buildings. Hire an IT connectivity consultant, put that into your budget to assess strategy for remote connectivity for your server location, whether you're going to do a cloud-based server or a clinic-based server. How are you going to do printing and scanning, and making sure you have a security strategy. Clinicians need to be involved in hardware considerations because of usability issues. You don't want to provide them with a piece of hardware that is not going to work well with their workflow. And just a note to really develop a very clear policy on security, particularly with bring your own devices, which would be the use of iPads and smartphones to avoid risk of any kind of personal health information and data breaches. To note, for support and resources, Health Center Controlled Networks, Yael's going to talk about this, and the network guide. Health Center Controlled Networks are a group of safety net providers who can help support your organization with IT project management, training and support, data management, meaningful use adoption, and hosting solutions. Moving through process development, as you begin your implementation and you strategize to plan it out, analyze your current workflow, and then redesign that workflow to meet the goals for data capture, patient engagement, and communication. And know that sometimes this is a shift in the way you deliver the care. It may change from where the paper chart and the physician sort of held the key to how a patient moved through the practice, that with a team-based focus and the ability using electronic medical records that multiple team members can be working on a patient's chart at the same time, really look at how you're going to map out that process, implementing clinical decision support and care coordination and management, and also discussing health information exchange strategy, because this is a part of meaningful use. Stage 2, how are you going to share that information with other organizations? How are you going to share it with the patient? And making sure that this is written out and shared with your staff, and again, providing opportunity for feedback. We're going to skip this slide. This is one of the most important slides, which is training, training, training. Never underestimate the power of people. People start where they are, not where we want them to be. Assess your staff's readiness. Adapt to their current levels of competency. If you have a tech-savvy staff, that's terrific, but you may have some staff that haven't keyboarded before. They don't have a computer at home. They may require extra staffing, but recognize that unless your entire workforce is trained, that the technology will not be used appropriately. Set realistic goals and make them manageable so it's not so intimidating and frightening. Patient engagement, Yael's going to talk about. And lastly, it feels like an overwhelming prospect. Take a deep breath and know that if you follow this, develop a structural framework and follow these guidelines, you have many resources, other healthcare for the homeless grantees who have done it before you, as well as many of the resources Yael is going to share with us. It is doable. We've had some healthcare for the homeless centers who are doing really well and moving towards stage 2. And so now I am going to pass the baton over to Yael Harris, and she's going to continue on and speak specifically about resources and patient engagement.
Thanks so much, Anna. Great job. I specifically love this slide. I think it's pretty funny. I was asked to speak about patient engagement and then share some of the resources we have. So I gave myself way too many notes, but as Anna said, I'm from New York and I talk really quickly. So I can hopefully get through all my slides, but I will try to do my best. So first of all, I want to let everyone know, if you're not aware, that in August, the NPRM, which is the Notice of Proposed Rulemaking for Meaningful Use Stage 2, came out. And there are several major features of this you should be aware of. One of the key features is information exchange, an enhanced focus on being able to exchange information across providers, because as you may have heard, a lot of people are criticizing whether health information technology has had an impact, and the real value is a chicken and egg phenomenon. You really can't exchange information until you have information electronically, but you really can't benefit from it until you can actually share the patient information across clinicians so that you can actually coordinate care better. Another major component is population health, so an increased focus on community health, advancing interoperability with public health departments, really a lot of what we do, which is helping to support a wider community focus on healthcare. Another piece that's really important is patient engagement, and I'm going to talk more about that. So considering the populations that we serve and the challenges we face in our practices, I personally think that patient engagement is actually the pivotal opportunity to transform our current healthcare system. So if you look at this slide right here, on the left is basically your ideal, what you'd love to see, but really what you see more is on the right, more like, can you hear me now? Patients feel like they're not being heard or no one's understanding them. Someone gave me an example yesterday. If you're talking about a mom with 2 young children and a single mom, and she's told to go on bed rest, the fact that she doesn't go on bed rest and gives birth to a premature baby is not because she wasn't trying to comply with the doctor's orders, but the doctor didn't take into consideration her circumstances and help make arrangements to support her needs better. So we really need to think about the whole patient and what their needs are. So the next slide is basically an article I found, so I'm not advocating this blogger, but I thought this was fantastic. So if patient engagement were actually a pharmaceutical company's newest invention, it would be the front page of the New York Times. But instead, it's relegated to what does that mean? We're already talking to our patients. So we really need to better understand why patient engagement is so critical and important. And I think a picture tells 1,000 words. So if you look at this, you can really see that patient engagement is really necessary to transform our healthcare systems. And clinicians can't do this alone. And the patient wants to be engaged. A lot of times people think the patient doesn't want to be engaged, but you'd be surprised at how many patients that clinicians think are not motivated actually want to be engaged. We just need to find the right way to engage them. So in the past, we used the carrot and the stick, and they were all focused on the clinician. Basically, if the clinician needs to move forward, we either offer them financial incentives or we offer them a financial penalty. But we really need to consider how to move beyond the walls of the clinician's office and take advantage of information technology at the fingertips of patients in every aspect of their life. So I thought this picture was particularly funny. Patients are really already looking up health information. They're already using the Internet to find others with common health conditions and illnesses. And then they're rating their doctors and locating different types of treatment. They're considered like an Angie's List for patients. So we're really moving in this direction, and we need to think more proactively about it. So this slide is kind of overwhelming, but I just love how it talks about the fact that where we could start at the basic level of adoption and move into innovative approaches to really reach out. And so I just want to give you a few examples of these. If you haven't heard them, and take notes, or I can send them to you later, and I would look them up. They're all available online, so you can look for more. I'm not advocating as a federal official any of these programs. I'm just giving examples of programs that are out there. So, for example, for peer-to-peer, Patients Like Me or Cure Together, and there's also blogs I found for parents of kids with ADHD. Within the communities, there's blogs for parents, and there's the Alliance for Health. Connected devices, the Fitbit, Nike Fuel. For transparency, there's Rate Your Doctor. There's actually ER wait times posted at a number of hospitals, so you can decide, how long it's going to take and if you could pick from between hospitals. Telemedicine, there's Teledoc, where you can actually get a doc consult at your desk. There's American Well. For virtual consultations, there's HealthWise. There's Airstrip. SMS, Text for Babies, one of the most famous, I'll talk about in a minute, or Text to Quit for smoking. Remote monitoring, you have Ideal Life, WellDoc. Mobile apps, you have iTriage or iStethoscope. Again, these are not all of them. Social media, Twitter and Facebook are really becoming homes for people to share information about their health. In fact, if you haven't watched, Twitter has been found one of the best ways to predict where the flu is taking off by people twittering, I don't feel well, and 3 days later they have the flu. Email, one of the popular ones is Cryptic. That's secure messaging between providers or patients. There's WebMD, and then gaming is really moving forward. Some of the newest ones I've heard about are EndoGoddess and Monster Manor for managing diabetes among children. So let me look at a few examples of these because they really are overwhelming and there's too many of them to think about. So Blue Button is actually a capability, is a tool that can allow individuals to access their health information so they can effectively participate and manage their health. A survey of nearly 70% of the public and 65% of clinicians agree that patients actually ought to be able to download their medical information online. This was a study done by Markle Foundation. So Blue Button is basically a simple solution to do this. It's a highly visible, clickable button where you can download medical records in digital form from a secure website. It's being offered by clinicians, insurers, and pharmacies. People log into a secure website to view, and they have the option to download the information so they can examine it, check it, and then go over it with their doctors if they feel necessary. Right now, the Veterans Administration has done this, and over 6 million veterans have downloaded their information with Blue Button from the My Healthy Vet, which is their patient portal. Currently, all Medicare beneficiaries can actually access their claims data on mymedicare.gov and then print a report to share with their caregivers. And CMS actually plans to implement Blue Button to allow beneficiaries to download their claims in a simple format that can be uploaded into their personal health record. And then a lot of public-private partnerships are testing files which personal health record vendors can actually download to use Blue Button. So it's really moving forward. And in 2010, the Markle Foundation and Robert Wood Johnson Foundation actually challenged developers to create applications to expand on Blue Button. And this resulted in an award for the VA on the Blue Button for All Americans, which basically makes the personal health record system pulling data through Blue Button available to all patients for more than 25,000 physicians across America that are enrolled in Relay Health. So as you can see on the slide, a number of insurers are actually participating in this, and it's really becoming the standard rather than the exception. So another thing is patient portals, which are really transforming things. Through a patient portal, patients can access information, and it's not just online. When you talk about rural areas, they may not have internet access, but they have cell phones or access to an iPad where they can get feeds on that. And just to point out, cell phones are ubiquitous. According to the latest data, 85% of American adults have one, and 53% of them use a smartphone, so they have access to the internet or email on their phone. And 1/3 of all cell phone users have said that they've looked up health information on their cell phone. So, and the other misconception is that cell phone use is only among those who are educated or wealthy. What we find is cell phone use is high among all groups, regardless of race. It's actually higher among blacks and Latinos, and it's actually very high among those who are not necessarily advanced education, because it's a real way for connecting and communicating. Homeless people are much more likely to have cell phones because this is their connection to the whole world. And caregivers who are facing a health crisis are much more likely to use their phone for access to health information where they don't have regular access. So the meaningful use beginning in 2014 is going to require providers have at least 10% of their patients accessing their information electronically. And the patient portal is really the key way to do this. And so I'm going to talk a little bit about why that is. First of all, it's timely access. So imagine if you are a mother of a young child and filling out your child's paperwork. This is my own personal example for enrollment in summer camp. You need to enter the date of his or her last immunizations. Currently, you have to call your doctor's office, send a fax of the paperwork that they want you to fill out, then have the doctor bring it to the doctor so you can signature, then fax it back and submit it to the camp. So this is taking a lot of time, and I personally have no more patience for this archaic approach to getting the information that I should have at my disposal. So this is my scenario, another scenario, which is my own personal one that you can understand. When I gave birth to my second child, doctors determined that based on my first delivery and the complications, that it was best to have a C-section. However, I'm allergic to canes like benzocaine and lidocaine, which they use in the epidural. So the doctor needed to operate as soon as possible. I was basically fully dilated, and they didn't want the baby to come out naturally. However, my allergist office was closed that Friday afternoon, so there was no one to report to my allergist that I had the test and topical canes were fine, and the type of cane they use in the epidural was fine. So here we are. I'm now at 9 centimeters. The doctor's freaking out because he doesn't know what to do. Does he have to put me under general anesthesia to deliver this baby? Finally, we reach someone at the allergist's office who faxes the records over. And in the 11th hour, or 9.5 centimeters, they finally managed to do a C-section to deliver my son with. Honestly, this is a perfect example of why there should be access to your health information and why patients should be access to their health information. So many of us have access to information and we don't even know it. I'm actually a member of Aetna, which means there's a patient portal, and I don't even know how to get to it. So really, we need to figure out
how to get this information and how to get it from trusted sources. My insurer is not a trusted source. The government is not a trusted source. But your doctor is usually your clinician is your most reliable source of information. So having this dialogue with your patients and letting them know where to get this information is usually a really great way to engage them in taking advantage of this. Another great feature is scheduling. Online scheduling is a real great asset. Everyone loves it, being able to go online. It's also a click to the portal. So if you put information out there for the patient, they may not go look at it. But if you require that they go online to schedule their appointments, then they're going to say, oh, let me look at this latest test result. Oh, I see it's out of range. So really helping move things forward. You can do online appointments. You can see when the clinicians are available, what their hours are. So it really moves things forward. And the last thing, which is really coming to the forefront, is secure messaging. So being able to actually dialogue with your clinician online. So it's really great to have an opportunity to electronically exchange data. It's secure. Settings where secure messaging is used, like Kaiser Permanente, Intermountain Health, and Geisinger, have all found secure messaging to be a valuable tool. It saves time and ensures more timely access, but it does require new workflow, so it needs to be taken into consideration. Some of those considerations are setting aside time during their day, blocking off time dedicated to responding to messages. Others elect to do this first thing in the morning and at the end of the day, and still others treat these as phone calls, so they fit in 1 to 2 between seeing patients. There's no perfect workflow design, but really this could help expedite your patient workflow and move things along in terms of better coordinating your patient care. The next thing that I want to talk about is the future, which is online clinician visits. So this is really moving forward. It sounds kind of like a Stanley Kubrick movie, but it's really happening. Google, Microsoft, Encore, Rent-A-Center, all these use this. The patient does not have to leave their office. They can actually have health care right then and there. They can get a prescription or referral, determine if an in-person consult is needed. They can actually do visuals of wounds, et cetera, so they can see it, the doctor can see it right there. At Intermountain Healthcare in Utah, this is actually done through the patient portal. So the patient logs on to their portal, and while they're doing their work, they just wait till the doctor's available. It says, doctor will be available in 5 minutes. The physician sees the queue of patients waiting on a consult, has access to the patient's entire medical record right there, and can do all the treatment right then. So it basically saves a lot of time for both the clinician and the patient, and it really is a convenience factor. So according to the statistics, the average online consultation is actually more cost-effective than an in-office visit. It can occur anytime, anywhere, takes less than 20 minutes, and actually has increased productivity for both the workers and the providers. It's less sick leave and increased patient satisfaction. And it's really a great way to move towards a patient-centered medical home, where patients really need access outside of your regular business hours, including evenings and weekends. So I've even heard of this type of technology being used in daycare centers, so the the mother doesn't have to take off from work, or I don't want to be the sexist, or the father, run to get the child from daycare, take the child to the pediatrician for the pediatrician to say, it's not a big deal at all, the child could have stayed at daycare. So really, it moves things forward, and it's really beneficial to everyone. So the other critical piece is information. So portals allow patients access to information. So according to Pew Charitable Trust, 59% of adults in the U.S. have turned to the Internet to look for health information online. And this statistic actually exceeds 80% when we look at those over 56, under age 56. But we're all really busy and moving in a million directions, and I just don't have time to Google everything I need. So this is where a portal can be great. A portal can be personalized and provide specific information to the patient. So if the patient goes on to make an appointment and then it prompts, did you know that the latest treatment for this condition is available? So it really moves you forward into personalizing that information. I actually am the mother of an asthmatic daughter. And it'd be really useful to have information on there about the latest breakthroughs in asthma therapy, the impacts of giving medication twice a day instead of once a day when she's having an attack and I want to be preventive. This information would be great rather than calling my doctor and asking for this information or even scheduling an appointment to have to go in to get this clarity. The next thing is MobileHealth. And MobileHealth really can transform health. Besides being in your pocket, it's now a key source of information, as I mentioned, from text alerts to the ability to look up side effects of medication, as you can see here, to actually finding the nearest doctor and determining where there's openings. It really can help move things forward. In some cases, health insurers have actually found MobileHealth and information can be even more helpful by directly delivering it through cell phones. So they elect to cover cell phones for patients with chronic disease. So applications to manage diabetes, for example, reminders for medications and text alerts, and even cell phones for veterans to help cope with traumatic brain injury through 24/7 access to mental health counseling, online support systems, and stress monitors. So really, it's transforming healthcare in the nation. One of the ones you may have heard about that's widely used is Text for Baby. It's a public-private partnership. It's already reached more than 500,000 pregnant women and new moms across the United States with information about healthy prenatal care and then postnatal care for you and your child. Something I wanted to announce that just happened yesterday is in the Federal Register, we just released a request for information on a new program that would not necessarily be linked to this, but could build on this, called Text for Tots, which would provide weekly messages to parents and caregivers, as well as clinicians could promote it on healthy nutrition and eating for parents of young children ages 1 through 5. So I encourage everyone to go to the Federal Register and look that up. It's called Text for Tots, TXT, the number 4, TOTS. And we would love feedback or information. And there's also an in-person forum scheduled for February 20th, where you could participate by WebEx or in person here in D.C. to share more ideas about how you as clinicians can use this information to inform and educate your patients. Exercise and fitness, I don't think I need to go into this. Everyone knows about what's going on with exercise and fitness and how it's being used. My husband is sold on the Fitbit. He actually competes against himself to see if he can do more steps each day. And it's been a great way to motivate him. So he's really working to improve his health. He can post that information on Facebook so that others can motivate him on. And I love that he's taking charge of his health rather than me being the nagging wife that I often can be. The next thing is gaming. And gaming really is, I think, the future of healthcare. And this is just a personal thing. But as we move, turning things to a game really moves things forward, especially when you think about children. If you look in the upper left-hand corner, Wii really gets kids motivated. We used to talk about kids being couch potatoes, and now they're using Connect and Wii to really become active. My daughter loves Just Dance 4, and it's great to know that when she's home and not outside playing, like when there's cold weather here in D.C., she's actually still being physically active. Another app that's down here by Duet Health is an app for children managing their diabetes. So as you do a good job managing diabetes, keeping your blood pressure in control, you get to feed your virtual pet. So there's a motivating factor to keep your virtual pet healthy. And after a certain number of times that the virtual pet's been kept healthy, you actually win a free iTunes download. So it really has some intrinsic motivation moving towards you. Some of the other things that are up here are programs that were just released by Aetna at the MobileHealth Forum, and they're really great. One's called Mind Bloom, and the other's called Juice, which you can look up, that are focused on how to do better jobs with your energy, physical activity, and dietary health, as well as now thinking about stress levels and how that impacts things. Remote monitoring is really a great way to move things forward, and it's really becoming universal. Everything from being able to do an x-ray and send that to your doctor, to monitoring your blood pressure and diabetes, to even doing a sonogram at home. So the real question is, how do we get there? This seems like we're light years away from that, but really we're not. It starts with using electronic health records and encouraging patients to engage in their health care. As providers, we really need to make sure patients have access to their information, and there's many ways to do this. As I mentioned, there's patient portals, which a lot of electronic health vendors use as part of their package. There's also free patient portals that are available to the public. There's tools like cell phones and other vehicles like games to encourage patients to engage. So instead of just checking off no change to health status, patients are forced to use a kiosk or a tablet to record their information and make their updates so they know what they're doing. So don't assume patients are not computer literate. With touchscreen technology, actually anyone of any age can use this and review this information, update information. So we need to be pushing this information out to patients, looking at how do we promote anything from text messaging programs to apps, and encourage them to check their lab results and make appointments online so that they become active consumers of their health care. And I wanted to let you know about some of the resources we have at HRSA to help you with this. So one of the resources we have is our online website. It's available at HRSA.gov/healthit. If you actually go to the HRSA main page, it's one of the bars you can click on the main page, and it'll take you right here, and it'll give you a whole list of resources. One of these resources is toolkits that we specifically developed with the safety net provider in mind. So all of these have been tested and validated for use by safety net providers. as we get into the new year, we actually hired a communication specialist to help us redesign these toolkits to be more interactive and better support health, as well as to include behavioral health and integrate it into our toolkits. Another resource we have that Anna mentioned briefly is the Directory of Health Center Networks. And these are health center networks, are resources that provide technical assistance and support. You can either get ad hoc support or become a member. And they provide guidance, everything from how to adopt an electronic health record to how to become a person-centered medical home. So they really are a great resource just to look up, find out what skill sets they have, what tools are available, and where they're practicing. If they have expertise in communities that are rural, whether they have expertise in homeless populations, a lot of them do, so that you can find one that best meets your needs. We also produce a monthly newsletter, which you can subscribe to by emailing healthit@HRSA.gov. We have a huge listserv of over 20,000 right now, and we're always adding to it. This newsletter provides updates on the latest information around health IT, including meaningful use updates, and the next thing, which we're very proud of, which is the grantee spotlights. So the grantee spotlights are 2 spotlights each month featuring a safety net provider that's effectively using health IT to improve quality. We have one coming up this month on MobileHealth. We're trying to look at different ways. We're moving towards patient portals and other vehicles. So we would love to feature you. If you have an idea, if you are effectively using technology to engage patients or move forward the agenda, please send us an email and let us know how to about your project so we can follow up and feature you on a spotlight that will get sent to our entire listserv and posted on our website for more people to see. We also feature webinars every month, and we look at topics that are most important. Our February webinar is focused on using an electronic health record and quality data to improve hypertension for National Cardiovascular Month. Last month we had a webinar on upgrading and optimizing your electronic health record with over 120,000 people online. These are all also available for download 2 weeks after the event. So we encourage you to look at our website, and you can see the how to get there online on top and take advantage of these webinars. We also create a meaningful use webpage that provides a lot of resources for safety net providers on meaningful use. So very high-level materials as well as links to more resources from CMS and ONC. And lastly, we've developed a MobileHealth webpage, which provides information about mobile health activities happening throughout the government, as well as some of the private sector activities that have been endorsed by the government. We can't just post private sector activities, unfortunately. And lastly, we have a telehealth webpage and a lot of opportunities for grants on telehealth, as well as examples of best practices and resource centers that exist across America funded by HRSA to support effective use of telehealth. And then I just wanted to give you that there's other online resources available, and I encourage you to check these out and take advantage of them. There's a lot of great resources on both of these websites to provide great in-depth information. And then other non-federal websites that may be useful for you. And here's my contact information, so I encourage you to reach out to me if you have questions, clarification, or would like more knowledge. And if you go to the HRSA.gov/healthit website, there you can subscribe to any of our webinars or to get on our listserv and to get our toolkits and grantee spotlights, etc. So with that, Anna, let me turn it back over to you, or I guess over to Melissa. So thank you so much, everyone, and I apologize for the amount of information I covered in a very quick time and the speed of my presentation.
Absolutely no problem, Dr. Harris. Thank you so much, presenters Anna Gard and Dr. Yael Harris. They were both dense and colorful, and I think we have a couple of questions from our participants. One for Anna. I will start there, though I think this might be a bit of a tricky question in general, and it's from a participant who's interested in the ability to bill for online or remote office visits. Anna?
So it's a terrific question. I think that it really speaks to how we need to look at, as we use health information technology and things like telehealth and online visits, how are we reimbursed for using that technology? And I think the technology has come in in advance of the shift in the healthcare payer system, where we're used to being paid for volume instead of value. And so I think at this point I can't speak specifically to what coding you use for billing an online visit. I think it's dependent upon each insurer and whether any of the insurers are covering it. I'm wondering if the HRSA Telehealth webpage would have some resources regarding what billing codes have been used, what insurances have covered it. I don't know, Yael, if you know of specifically any resources, but I do know that in terms of this is an area where the technology has really come in advance of us catching up in terms of reimbursement and payment.
So absolutely. So reimbursement for telehealth is still late in coming. The private sector is really leading the way. I know a lot of the Blues cover this. I had conversations with Aetna, and they're very interested in covering this. I think your best resource is to actually contact the American Telemedicine Association, which is American telemed.org, I believe. I apologize, I can't recall. There's new bills on Capitol Hill that were just announced the last few weeks to move forward for more reimbursement for telehealth. One of your other resources is going to that website I mentioned on telehealth and contacting your local telehealth resource center. They can provide you a lot of personalized information about what's going on, specifically because Medicaid often covers telehealth more extensively than Medicare does. And while private insurers had been copying Medicare, they're starting to look at Medicaid as the role model.
Thank you so much, Anna, for that response, and Dr. Harris for the follow-up. Dr. Harris, I actually have a couple of questions for you, and you referenced a toolkit for safety net providers. So one participant is interested in maybe a little elaboration on what all is included in that toolkit for safety net providers and how useful it is for providers of special populations.
Absolutely, my pleasure. Thanks. In the toolkits, we have a variety of resources. So we have everything from how to plan, how to execute, how to work with staffing, leadership issues, all related to telehealth, as well as how to evaluate the effectiveness of your program and do redesign. These tools were developed with safety net providers in mind and have been particularly useful. They're also broken down by sections. So when you go to the toolkit link, what it gives you is a series of questions as opposed to a long didactic text. And then you click on the questions you have to get information helping to answer those questions. It also provides links to other resources that are often great. So it may connect you to other information sources that you may want to use in your regular practice that have proven to be best practices in the field.
Thank you so much, Dr. Harris. And so a follow-up question also to one of your slides related to meaningful use incentive programs. Can you elaborate on either the existence of and or any other information to get in touch with these incentives?
Sure, absolutely. So the Meaningful Use Program is still in what's called Stage 1. As you saw on the diagram Anna displayed, there will be 3 stages, and there's discussion that it won't end there. Right now, it is basically a voluntary incentive payment program. So if you reach the criteria for Stage 1, you can get an incentive payment. The other thing is for Medicaid incentive payments, in the first year, you do not have to meet Stage 1 criteria. You only have to testify that you have adopted, implemented, or upgraded your current electronic health record. So if you didn't have an electronic health record and you adopt one, as long as it's certified and you testify to that, if you had one but you upgraded to make sure it met the criteria for Stage 1 of meaningful use, all those are valuable for the Medicaid payments, and the Medicaid payments are actually more generous than the Medicare payments. Moving forward, you'll need to meet Stage 1 of meaningful use, and the proposed rule that I mentioned in August was for Stage 2 of meaningful use. If you go to our website on meaningful use, you can see all the details about what the criteria are for both of those, and we're working on updating our Stage 2, Meaningful Use Stage 2 website to provide even more context and more information. The final rule should actually be out this winter, in which case then we'll completely update it. There's also resources for helping to reach meaningful use. There's the local regional extension center, which is within there's at least one within every state. There's multiple in the state. If you go to the ONC website, helpit.hhs.gov, you can find them, and they're providing technical assistance. You can also use the health center controlled networks. We really think this is a hard process to do by yourself, so it's best to actually partner with someone else who can help you walk through and help you make sure you don't, to avoid the pitfalls. The incentive payment program is supposed to extend through it will extend through 2016. There's discussion that it may even extend longer just because of the amount of time needed to implement the program. However, penalties are due to begin shortly for not necessarily Medicaid, but for Medicare docs that have not effectively met meaningful use. So that will be the stick that will come in a couple years from now. And if you do have a Medicare population, that's something to think about. You need to have a 30% Medicare, 30% of your patients be Medicare to qualify for Medicare. For Medicaid, there's different rules based on pediatrics, or if you're considered a federally qualified health center or rural health clinic.
And if I can just add to that about the National Healthcare for the Homeless Council, on their website, we have a meaningful use resource catalog, which provides you with links to resources and steps to engage in the process. So I would encourage you to go to our website and start with the resource catalog, because that will help you move through the process.
Excellent. Sorry for that, Anna. So thank you again so much, Dr. Yael Harris, for that dense and really exciting presentation on meaningful use. Thank you so much, Anna Gard, for bringing these excellent bits of content to us on PCMH and meaningful use. Anna alluded to a couple of other resources we have in this area. On our website, we also have, in addition to the archived webinars from the past with other health centers and other healthcare for the homeless grantees, we also have a slew of publications, including Anatomy of Implementation, the Structural Framework for Meaningful Use of Electronic Medical Records, a 9 Steps to NCQA PCMH Recognition, and an FAQ on PCMH for HCH projects. And as Anna mentioned, during our national conference in March in D.C., March 13th to 16th, we'll also have workshops that touch on both of these topics, as well as the availability of TA on both of these topics, PCMH and meaningful use for HCH or health center grantees. So thank you all again for participating in today's webinar. Thank you, presenters, Dr. Yael Harris and Ms. Anna Gard. We so appreciate you taking the time out of your day to listen to this content. So that we may improve upon our content, please take our survey and evaluate this production as you exit, and give us your feedback. Let us know what we're doing well and what we should improve on. So with that, thank you all. Have a terrific rest